basically, this is a retrospective multicenter study, and we have three participating centers. So we have the University of Florida, Baylor College of Medicine, and the University of California, San Diego. And we started off with reviewing 541 total charts, which we identified by the slicer dicer extraction tool through EPIC, and to identify all MOG positive patients. And we identified a total of 88 MOG positive patients and excluded 12 of those, 8 because they didn't fulfill the MOGAD diagnostic criteria, and 4 because they had not sufficient follow-up times. So that left us with a total of 76 patients. So as I already mentioned, with the relapse data, about 2/3 of these patients relapsed, and relapse times varied with the vast majority, about 2/3 again, relapsing within first year, but 19% relapsing 5 or more years after. And then looking at different predictors, the predictors we found was a pediatric onset of disease, younger than 9 years, with a positive predictive value of 92%, meaning that only one of the 13 patients did not relapse. Then a Hispanic ethnicity, actually something that multiple other centers have reported now as well. So of the 15 patients with Hispanic ethnicity, self-reported Hispanic ethnicity, 13 relapsed. And then we had also a clinical syndrome of meningoencephalitis, where we had 5 patients who presented with this, and all of these patients relapsed, as well as 5 patients with a profound pleocytosis of 150 or more cells. And here again, all of those 5 patients relapsed. And this is something that a prior group had also reported by Wang et al. With a smaller cohort, but they also found pleocytosis. They had the cutoff at 50 as a potential risk factor. And then there's also repetitive thoughts about, does the height of the anti-MOG titer play a role? And there were different prior groups who suggested that, including MGH, including Wang et al., and also that potentially a persistent MOG titer, presented by Mayo in 2018, may also be a risk factor for relapsing. And we also found that ictal titers, so titers during the exacerbation that were very high, so 1 to 10,000, at least 1 to 10,000, it was a predictor for a relapsing course with 5 out of 6 patients relapsing, and also a pretty robust intra-ictal titer of 1 to 1,000, which basically all of those patients developing a relapsing course, which was 4 patients. Lastly, I already touched base on immunotherapy. So we don't have a lot of data for what to do in patients with relapsing MOGAD. So we looked at our relapsing MOGAD cohort and looked at the most utilized disease-modifying therapies, which were anti-CD20 therapy, mycophenolate, and IVIg. So we saw that anti-CD20 therapy, and that's kind of mirroring different groups, even though our data was a little better. 13 out of the 24 patients remained relapse-free, which still means a very high relapse rate. The same for mycophenolate. So 6 out of 10. 60% of patients remain relapse-free. And we are also mirroring the findings that IVIg may be here the most promising maintenance therapy, where 11 out of the 14 patients remain relapse-free, so 78.6%. So that's basically the most important findings from the study. It's a retrospective study, and that's one of the biggest limitations. Also, the due to the retrospective design, there's heterogeneous data. There are varying follow-up times. Follow-up may not have been long enough. Our median follow-up times for the monophasic patients was 24 months. So if you think that some patients may not be developing their first relapse until like 5 years after the initial presentation, we may not have caught all of these relapsing patients. And then also, especially for the predictors, we still have a pretty small sample size. So I think the most important thing here is that we need more independent cohorts that validate these different predictors.